Baby, I see this world has made you sad. Some people can be bad. The things they do, the things they say. But baby, I'll wipe away those bitter tears. I'll chase away those restless fears. Turn your blue skies into gray. Why worry? There should be laughter after pain. There should be sunshine after rain. These things have always been the same. So why worry now? Why worry now? Baby, when I get down, I turn to you, and you make sense of what I do. And oh, it isn't hard to say, but baby, just when this world seems mean and cold, our love comes shining red and gold, and all the rest is by the way. Why worry? There should be laughter after pain. There should be sunshine after rain. These things have always been the same. So why worry now? Why worry now?
Welcome to the IgG4 Foundation Fireside Chat for the month of April. We're delighted to have you here. In a few moments, I'll introduce our special guest, Dr. Emanuel Della Torre from Milan, Italy. For the past few minutes, you've enjoyed, I hope, some slides from the 5th International Symposium on IgG4 related disease, which as I think you can tell, was a wonderful occasion for all 290 attendees who attended the meeting. I want to review quickly the fireside chats that we have had to date. We started in November of 2023. Then in December, Emma Culver and Arzuko Rashahi joined us. In February, Corey Perugino gave an overview of the science of IgG4 related disease and a patient-centered presentation. And I'm pleased to say that that presentation has been viewed now no fewer than 500 times on YouTube. Today, Emanuel will join us for a recap of the IgG4 Symposium. And let's see. In May, Catherine Provencher will join for a fireside chat. Catherine is our Director of Patient Advocacy, and she and I will answer questions. I believe that Emanuel and I probably will not have time to get to questions today because we have so much to tell you about with regard to the symposium. But Catherine and I will do a special fireside chat on May 31st. To address questions and answers. In June, we'll be joined by Professor Matthias Löhr from the Karolinska Institute in Stockholm and Guy Katz from the Massachusetts General Hospital in Boston for a special session devoted to the pancreas. And then in September, we will take up the question of vaccines and the prevention of infections. This is a very timely topic and has been for the last several years. It will be even more timely as we move into the fall and the virus season and hopefully the first drug approval for IgG4 related disease. Before we proceed, I want to read the IgG Forward mission statement. Our mission is to improve the lives of people living with IgG4 related disease through education, expanding disease awareness globally, facilitating groundbreaking research, and being the trusted source of truth for IgG4 related disease patients, caregivers, and healthcare providers. Moving on to a few announcements now, I want to remind you of the wonderful caregivers conversation that we had back in March, led by Catherine Provencher and Sabrina Riddle and Linda Bamber and Josh Argall, all just fantastic, emotional, articulate speakers about what it is like to have a chronic disease. This is available on our website, and I encourage you to go back and view it again. Just a wonderful piece. We will have another caregivers conversation, again led by Catherine, in October, on October 18th, and the special topic will be IgG4 related disease and your mental health. Our online community has launched. It is less than a month old, but our baby was born on April 1st. We look forward to getting your feedback about that. At some point, it is growing in a very robust way, and we are delighted by that as well. Our IgG4 related disease physician network will launch next month, probably very early in May, and we will have many dozens of physicians within this network at the kickoff. We plan to continue to expand this network on a continual basis because we recognize that one of the biggest challenges as a patient with IgG4 related disease is finding a physician who is familiar with the disease near you. So look for the launch of the IgG4 related disease physician website in early May. And we'll move now to the meat of the presentation. I'll introduce Emanuel in just a moment. Updates from the Milan Symposium for people living with IgG4 related disease. This was the 5th symposium that Emanuel led in Milan. The first was in Boston 13 years ago. Now, this is a picture taken of the first attendees in front of the Massachusetts General Hospital at the first symposium. And one of the wonderful traditions that we established at that meeting was to have all of the attendees sign the poster. And you can see the signatures of all of the attendees at that very first symposium. I treasure this. It is framed. It is on my wall. And for this symposium, we did the same thing. This is a picture of the attendees taken in front of the Duomo in Milan. It was the last day of the meeting, so some of the attendees had filtered away, but you can see the much bigger poster, which contains all of the signatures of the attendees. And this is something we took lots of pictures of, and it is also a treasure. And without further ado, I'd like to ask Emanuel to turn on his camera so that we can see him. There he is, Emanuel. Welcome, and you are still glowing, I'm sure, as I am, basking in the light of the wonderful symposium that you held in Milan just a few weeks ago. So thank you very much for that, and thank you for being with us here today.
Good morning, everybody, or good afternoon or good evening, depending on the continent where you are connecting from to watch live this fireside chat. I am Emanuel Della Torre. I'm an immunologist and rheumatologist working at San Raffaele Hospital in Milan, Italy, and I lead the IgG4 related disease clinic. So thank you, John, really very much for your kind introduction, but most of all for being such a great mentor for my last 10 years of story with IgG4 related disease. I still remember when I first came to Boston nearly 13 years ago, which was basically the start of my adventure in this disease. And I must say that at that time it was really unbelievable to me to organize the 5th International Symposium afterwards. Well, this means that we have worked very well together. We kept collaborating. We really did a great step forward in understanding this disease. And if we were really able to put together such a symposium with such a lot of participants, it means that the community is growing and the knowledge of this disease is increasing worldwide, and also the interest from clinicians, pharma companies, and also patients are realizing how important they can be structuring themselves in groups. We've seen groups raising from Facebook and from other social media. We have organized also a live meeting with Italian patients with IgG4 related disease last autumn. So everything all together is becoming really an exciting adventure that started a long time ago, as you pointed out. So yes, this is me, and this is the logo of the 5th symposium of IgG4 that we organized. I like to say that I did not organize anything alone. I did it together with a fantastic group of people, starting from the organizing secretary to of course, the organizing committee, and of course, together with Professor Stone. John was the co-chairman of this symposium, and without him, really few would it be possible. Next slide, please. Just to show.
Let's proceed.
Yes, just to show myself.
Here is Emanuel opening the symposium with a few opening day jitters, butterflies. Actually, none were apparent. And why don't you start us off with
yes.
statistics about the attendees?
Right. You saw myself on the podium, very excited because I was giving these numbers about the participation of the symposium. So as I mentioned, we hit nearly 300 participants, but I'm sure we were more than 300 because a lot of people joined later on and registered afterwards. Most of the participants were clinicians, of course, and this was great news. But we also like to mention the participation of patient representatives. We had 10 of them, and of course, pharma companies. All these things, again, witness the increasing awareness of the disease and interest worldwide about the disease. We received a lot of scientific contribution, namely 100 abstracts, which were of very high quality, with topics spanning from unmet needs regarding patient management to hardcore science and basic pathogenic experiments and stories to share with the community. Next slides, please, just to show how the distribution of these clinicians was. Basically, we had participants from all over the world, mainly from Europe, of course, but also from North and South America, Japan, China, and interestingly, also from areas that probably have contributed in a minor way to the publication on PubMed so far, but they are becoming increasingly interested in IgG4, and it was very, I would say, rewarding to see people coming to ask for joining the international works and the registries and the collaborative efforts that we are putting together from Australia, from North Africa, and Malaysia, Taiwan. Most of these clinicians, and next slides, please, were, of course, rheumatologists, clinical immunologists, and gastroenterologists. So these basically are the main specialties that are taking care of patients with IgG4-related disease. But we also had an interesting representation of other specialties, including ENT and ENT specialists and surgeons from different specialties, radiologists, hematologists. And interestingly, we also had a good representation of medical students and resident students, which is very important to us and to the community because they will build up the future, I would say, community and brains thinking about the disease and how to proceed in the futures, both in terms of science and in terms of treatment and management. So again, this symposium, I think, was very successful, mainly because of spreading the word around from Europe to the rest of the world.
And indeed, this was the most successful symposium in terms of attendees by a factor of 2. I think in the previous in-person symposia, we had not had more than 150 attendees. Here we had attendees from all over the world. The virtual symposium from 2021 was in Japan, and I think there were about 200 attendees for that, but they were all Japanese because no one else could go to Japan for that.
Yeah, unfortunately, because of the COVID pandemic, right?
Right.
Actually, John, when I was declaring these numbers in a very excited moment, you jumped in with another very exciting announcement, right? Soon after these slides.
Indeed, yes. So I'll move on to that. But I will say also, before leaving your stats, the science in the abstracts at this meeting was really extraordinary and just a huge jump from the science at previous meetings. I was very excited to see that with great stuff from investigators from all over the world. Then I spoke right after Emanuel, and I made the observation that there are many remaining mysteries about IgG4 related disease. And it was the 4th of April that we opened the meeting. And April, of course, is the 4th month of the year. And the 4th year of this decade, the 2020s, and it was the opening day of the IgG4 related disease symposium. So by the power invested in me, I proclaimed April 4th, henceforth, to be IgG4 related disease. This was met with great applause. And within a couple of weeks of getting back from the symposium, the governor of Massachusetts had already agreed that henceforth, April 4th, shall be IgG4 related disease day. And this is an effort that IgG Forward is committed to pushing ahead, and will anticipate other approvals as well. So it was highly appropriate to do this at the meeting. And Emanuel, now we'll move into what for you, I think, was one of maybe the greatest highlights of the symposium.
Right, John. When we conceived first the program of the agenda of this meeting together with the organizing committee, we were kind of inspired from previous symposia, and we wanted to obtain something new, to move the field forward, at least from a certain perspective. In the past, I clearly remember how we gathered to put together guidelines for the diagnosis of IgG4-related disease, for the nomenclature, so for the proper naming of the disease, and later on for the classification criteria, for putting together the ACR Euro classification criteria that we're now using for our clinical trials. So we also wanted the fifth symposium to be remembered for some advancements in the field. And I think that probably there were two main step forward, two main advancements from this symposium. One is something that you're going to mention after a couple of slides about the clinical trials that we are developing in the disease. But I think that these slides nicely summarize what was probably the other major achievement here. In Milan, we were able to put together around a round table, which was not a round table as Mr. Zucconi mentioned. It was, of course, a normal table, not a round table. But in any case, we managed to put together patient representatives from the US and from Europe, and have them discuss in front of the entire scientific community of IgG4-related disease about unmet needs for what pertains the approach from the patient perspective to IgG4-related disease. And this was really, I think, a great success, because we did it on purpose to put this roundtable for patient discussion at the beginning of the meeting, right at the center, at the heart of the opening ceremony, because we really wanted patients to start proclaiming their voice in this field, and see how together we can advance again our knowledge on the disease. So we asked representatives from IgG Forward and representatives from ERN Recognet to discuss for an entire hour in front of the scientific community about the main, I would say, aims, objectives that the research, that the scientific community should address in the next year, that might also overlap with interests, specific interests and personal interests from the patient perspective. So to guide us, to take this roundtable as an opportunity to speak to the scientific community. And indeed, this was a very productive moment, I think, which lasted for an entire hour, led by Mrs. Ilaria Galetti, an IPAG representative from the European Reference Network, which was very skilled and already used to lead these kind of roundtables and patient meetings. She herself is a patient. And so basically, during this hour, these two main opportunities and institutions for patients were presented. The IgG Forward and the European Reference Network, in particular the European Reference Network for IgG4-related disease. So if you allow me, John, I would take just a couple of minutes to introduce this European opportunity for European patients that goes exactly in the same direction as IgG Forward, and we have already discussed about the possibility of collaborating between these two organizations to pursue the same mission. So basically, European Reference Network for IgG4-related disease is one of a number of networks focused on a better understanding the epidemiology of rare connective tissue diseases in Europe. So together, in addition to Ehlers-Danlos syndrome, myopathies, relapsing polychondritis, lupus, Sjogren's syndrome, systemic sclerosis, and others, IgG4 was indicated by the European Commission as one of the emerging rare diseases where we still know very little about. So the European Commission wanted to put together a group of experts across Europe that might lead a number of activities that I'll discuss briefly in a while on this topic. So the European Reference Network for IgG4-related disease is now includes 67 clinicians, members, experts from 35 centers across 14 European countries. And Dr. Tobias Alexander from Le Charité in Berlin and me, myself, we are the coordinators of this group. And we try to work on different areas shown in the next slides, where we try to tackle this disease according to the guidelines provided by the European Commission to better understand the clinical manifestation of the disease across Europe. But in particular, the idea here is to highlight what are the excellent centers across our continent where patient can be referred to seeking for specialized expertise in treating IgG4-related disease. So that's the main mission of ERN, is to provide some information to patient and to create a network where complicated cases can be discussed on a common platform by European experts. And together with that, there are some other aims nicely pointed out in this cartoon. So we are working and try to improve registries and long-term data about IgG4, the education and training, of course, of medical students and residents, favoring experiences cross-border in excellent centers, between these excellent centers. So basically, this is, I think, a useful tool for European patients to help their mobility across countries and eventually to identify the best tertiary referral care centers in the European continent for their disease. And these are the links for useful links for contacts and for more information about the network, which is, again, I think growing with the same spirit of IgG forward. So it's going to be interesting in the future to collaborate on this and to share knowledges and experiences about that. Basically, after the presentation of these two initiatives, patients around that table discuss about the topics that you see mentioned here. So need for early diagnosis, the consequences of a delayed or a misdiagnosis, the problems that IgG4-RD might create in terms of mental health and approach to everyday activities. The impact that this kind of diagnosis has on family and social relationships, and of course on family economy. And we also briefly touch upon differences in access to therapies across the world, because these differences are there. They're clearly visible between Asia, Europe, and the United States, if not because of insurance issue, because of differences across healthcare system also in Europe. So all these aspects have been discussed, and hopefully in the future might serve to guide also research, clinical trials, and eventual patient-driven initiatives. So basically, to sum up this first, I would say, opening ceremony, it was very clear that with IgG Forward and ERN Reconnect, patients are now at the center of the IgG4-related disease path. And patients in particular now have two important resources, reliable resources, wherefrom they can retrieve information for their disease, for identifying the closest tertiary care referral center, to be framed, to discuss with experts, and of course to seek for eventual potential future updated treatments.
Thank you very much, Emanuel. So we'll move now into updates on clinical trials, which was also a very important part of the symposium. This was, in fact, the last talk of the symposium. And in particular, I'm going to focus on Mitigate, the Mitigate trial, a randomized double-blind trial of inebilizumab in IgG4-related disease. So inebilizumab is an anti-CD19 monoclonal antibody that targets a cell that we have believed for a long time now, namely the B cell. Plasmablasts are B cells. We believe that these cells are critical cells in this disease, going back just about 15 years now, and we are now completing, as a worldwide effort, a randomized double-blind placebo-controlled trial to test this hypothesis. I can't underestimate the size of the challenge and the importance of this accomplishment in doing the first worldwide clinical trial in this disease. It involved 80 clinical sites across 22 different countries on 5 continents. Really an extraordinary undertaking. It's the largest prospective trial of B-cell targeting therapies to date. It's the first controlled, meaning there's a comparison group, prospective study of B-cell depletion in IgG4 related disease. It's the first study to use the American College of Rheumatology and European League Against Rheumatism IgG4 related disease classification criteria as the basis of enrolling patients in the study, and it may lead in over a fairly short time period now to the first drug approval in IgG4 related disease. Only 20 years since the disease was first recognized as a unique condition, we may have the first approved drug. That is very, very fast. When I compare this to ANCA-associated vasculitis, a disease to which IgG4 related disease is often compared, it was 80 years after the first description of that disease before a drug was approved for that condition. So this is very swift, and it will be a great day for us all to celebrate, and we hope that will be here soon. Here is the design of the Mitigate trial. Patients had to have active disease at the time they were enrolled, and they had to be on steroids for the treatment of that disease. They were then randomized to receive either inebilizumab and a short course of prednisone, or placebo and that same short course of prednisone. The primary endpoint in the trial was measured at 52 weeks, and that is a comparison of time to relapse in the 2 treatment groups. So the wonderful news at this point is that enrollment was completed a year ago in April. 135 patients were enrolled. The last patient enrolled finished 1 year of follow-up on April 9th, I believe. And so now with Amgen, the trial sponsors, we are busily starting to analyze the data. We have been working for months to clean the data and make sure all of the data points are captured. And now we've moved into the very exciting analysis phase. We will know the answer probably sometime this fall. But I'm able to present a lot of data about the disease characteristics of patients in the trial and the investigators who conducted the trial. So first of all, what types of physicians contributed patients to this trial at these 80 sites across the world? 44% of them were rheumatologists, 24% were internists, 17% were gastroenterologists, specifically pancreatologists or hepatologists. And then there were also allergists, immunologists, nephrologists, and pulmonologists who contributed to the study population. This is what the trial patients look like. And I have to give a big thanks to the 135 patients who participated in the trial, and the even more patients who were screened for the trial, but maybe for one reason or another were not eligible. But they literally rolled up their sleeves to help advance the cause of research and treatment advances for all patients with IgG4 related disease across the world. They were on average 58 years old. 65% of the patients were male, and this tells us something very important about the disease. It is very consistent that there are slightly more males with this disease than there are females. That is an interesting finding. It's consistent in study after study, and it is different from other diseases that we consider to be of an autoimmune basis. Most autoimmune diseases have a female predominance. IgG4 related disease has a male predominance, and we don't quite understand why that is. One of the many mysteries about the disease still. Now, the patients were from all over the world. 39% of the patients were enrolled from Asian sites, 33% from European sites, 16% from the United States, and 13% from others. It really was a worldwide trial. The body mass index of the patients was normal, quote unquote, normal. And this, I believe, is a striking finding, and it's going to be interesting to look into this. Most patients in clinical trials of autoimmune diseases, the patients have a much higher body mass index. If one considers clinical trials of ANCA-associated vasculitis patients, for example, the disease I mentioned earlier, their mean BMI is much closer to 30. The patients are much heavier. In this trial, I think this probably speaks to the prevalence of pancreatic disease in the patient population. And pancreatic injury resulting from the disease makes it difficult for patients to gain weight. And I think this is why the BMI of our patients was relatively low. In terms of disease history, about half of the patients were newly diagnosed when they were enrolled, and a little bit more than half had relapsing disease at the time of enrollment. With regard to the number of organs involved, these patients had a lot of organs involved, either at the time they were enrolled or in their disease history. So 41% of the patients enrolled had either 2 or 3 organs affected at screening or before screening. 24% of the patients, a quarter of them, had at least 6 or more organs involved. One patient had a history of involvement of 13 organs, very, very typical of IgG4 related disease. Now, the next few slides show the specific organ involvement. I talked about the BMI being normal or low compared to other disease cohorts. That, I believe, is because 52% of the patients had histories of pancreatic disease. We're going to spend more time talking about the pancreas in June at our fireside chat, but the pancreas is a very important organ in this condition, and somewhat more than 50% of the patients in the trial had that. The bile ducts were also involved in 31% of the cases, and 7% of the patients were said to have liver disease. Now, the biliary disease, the bile duct when the bile ducts were involved, the pancreas was involved in all of those patients except for one. So it's very unusual in IgG4 related disease to have only bile duct involvement without also having pancreatic disease. In contrast, conversely, 41% of those with pancreatic involvement did not have biliary tract disease. So let me review this very quickly. The bile ducts, the anatomy here is complicated, but this is the liver, and these are the bile ducts. The liver makes bile, which helps us digest food. And the liver secretes the bile into these ducts, which ultimately empty into the small intestine. The pancreas is in close quarters with the liver and the bile ducts. It's behind the stomach. The stomach is right here. You can see the pancreas also has ducts, and the pancreatic duct empties into the common bile duct, joins with those bile ducts from the liver to form the common bile duct, and then also empties its contents into the small intestine. So the pancreas can be involved by itself in IgG4-related disease. It's very unusual to have only bile duct involvement without pancreatic disease at the same time. With regard to the distribution of other organs in the trial, major salivary gland involvement, very, very prominent. And these are the types of patients that rheumatologists tend to see. So you may remember this picture of this patient. This is the first patient, believed to be the first patient described in medical history. He was described in 1892 in Germany. He had lacrimal gland enlargement, parotid gland enlargement, and massive submandibular gland enlargement. And all of these disease features were well represented in this clinical trial. So it's really remarkable when you think about it. In 1892, this gentleman had this set of features, and now advanced the clock 130 years, and we are finally getting to the point of studying this disease, and the patients had exactly the same characteristics that this patient had. Other disease characteristics, other organs were well represented. The kidneys in 1/3 of the patients, the lungs in 1/4 of the patients. Allergic phenomena are very common in IgG4-related disease. They were well represented with sinus disease. The retroperitoneum and the abdominal aorta were involved in a significant number of patients, as were the orbits, the area around the eye, and the extraocular muscles, the muscles that move the eye. So suffice it to say that the organ distribution of the patients enrolled in the Mitigate trial was spot on for what we think about when we think about IgG4-related disease. Now, the trial population was very representative of this disease. There are going to be so many different analyses that come out of this trial. This is going to be an interesting one. What were the findings that led to the assessment of a potential flare in this disease? 75% of the time, the patients had symptoms associated with the evaluation of that flare. 63% of the time, it was a laboratory abnormality that led to the assessment of the flare, perhaps a rising serum IgG4 concentration. In almost 60% of the patients, it was a physical examination finding, perhaps the recurrence of submandibular gland swelling or proptosis, a prominence of the eye from orbital involvement. In almost 20% of cases, the flare was identified incidentally because of radiology studies, sometimes performed for other reasons. And those radiology studies identified IgG4-related disease activity or potential IgG4-related disease activity. It's going to be very interesting to probe these issues further. So the Mitigate conclusions for now, we won't yet know the results of the trial for another few months after lots of intense analysis, but this trial overcame a lot of unique hurdles. It achieved its enrollment goals, and the population, as I have indicated, was highly representative of patients with this disease. And ultimately, I think the results will be a fair representation of the efficacy of B-cell depletion in this treatment population. Let's break the code. We are all ready to know the answer. I should also mention in this clinical trials update that I talked about the Indigo trial. Indigo is another worldwide clinical trial being conducted on 5 or 6 continents. It will likely be even larger than the Mitigate trial. And the Indigo agent is obexelimab. It's given by a subcutaneous administration. It also binds to CD19, which is a target on B cells here. And part of the molecule also binds to a receptor also on the surface of the B cell called Fc gamma R2b. When these two receptors, CD19 and Fc gamma R2b, are bound together, the B cell is downregulated. So enrollment for that trial is proceeding very nicely, and we are really at a very fortunate time in the history of this disease to have two therapies in advanced stages of development. Emanuel, please take us through the next highlight of the symposium.
Yes, thank you, John. Indeed, what you just told us about these two interesting clinical trial nicely set the background for what I decided to pick up from the symposium to be highlighted. Mainly, I think three interventions, three talks from three distinguished speakers can nicely advance our knowledge about how to approach treatment of patients with IgG4-related disease. You just told us about two drugs that likely and hopefully will work very well and hopefully will be approved soon. But in general, when we come from the clinical trials to the real life, things might change somehow, because we know very well that IgG4-related disease is a I would say, a proteoform condition, a disease with a really high number of possible manifestations. And oftentimes when we get to real life, we realize that these little differences or large differences among patients might affect the regimen of or the dose of the drug that we want to administer to our patients. So in order to better understand how to deal with this, how to eventually modify both the pacing, the frequency of administration, or the dosage of administration of this drug, we really have to better understand what is driving the disease, how the disease is presenting, and why it's presenting in different ways in our patients. So basically, we need to know more about the pathophysiology and about the epidemiology of the disease. On day 2 of our symposium, we then discussed about both of these topics, epidemiology and pathogenesis of IgG4. The first talk that we wanted to highlight was the one given by Dr. Zach Wallace from Boston, from the Massachusetts General Hospital, who nicely drove us in a 20-year history of changing epidemiology of IgG4-related disease. We now know that there are phenotypes of the disease, and these phenotypes are different in terms of clinical manifestations, serological findings, and also some epidemiological findings. For instance, we know that IgG4 probably is much more frequent in male than in females, but this is not probably the case for head and neck limited manifestation, when we see that this unbalanced prevalence is basically equalized, so male and females are equally affected by this phenotype of the disease. And probably there are different pathogenic aspects or causes that support and sustain this different epidemiological feature of the disease. In particular, if we want to tailor our treatments to patient presentation, we also need to understand what is leading to what is conditioning the prognosis of different phenotypes of the disease. So in the next slides, Dr. Zach Wallace nicely highlighted what are the reasons, what are the main causes of morbidity in IgG4-related disease. Morbidity is not necessarily mortality. Morbidity means what might affect the efficacy of the drug, or the adherence to the treatment, or the quality of life in general of patients affected by a specific disease. So in this case, it was clear that the number of features inherent to the disease itself, or to the treatment that we're giving to our patients so far, we have been giving so far to our patients, might impact all these issues. In particular, depending on the organ affected by IgG4, we know very well that there might be complications related to pancreatic insufficiency, kidney insufficiency, lung respiratory insufficiency, and so on. making even more difficult to treat the disease, because we don't simply want to give a B-cell depleting agent, an immunosuppressive agent, but we also have to deal with organ-specific signs of failure and to replace eventually the function of organs affected by IgG4. So the extent to which this new drug on the horizon might impact all these features is unknown and will have to be assessed, verified, and carefully studied in real life. For sure, we might say it from now that these new drugs that will be hopefully soon approved might, on the long run, decrease the overall dose of glucocorticoids that are currently required to maintain the disease under remission. And in fact, Dr. Wallace highlighted how toxicity related to glucocorticoids and to the infections associated with long-term glucocorticoid treatment might also impact our treatment choices and decision making in patients with IgG4 related disease. Next slide, please. Actually, things become even more complicated when we realize that IgG4 disease might also affect children's. In this nice talk given by a Turkish group, we understood a little bit more about differences in the epidemiology and organ manifestations of IgG4 affecting children and adults, and discovered that in children, IgG4 affects much more frequently the head and neck rather than the systemic organs. And this might potentially have an impact in our treatment and decision making on the long run as well. But going back to my first slide, there were additional talks that we thought might be an interest to share with you and with the community about interesting novel pathogenic feature of IgG4. So in the next slide, I pointed out actually, in the next one, this is something that I probably already mentioned. We got into how the clinical variability of IgG4 related disease might be probably driven by an interplay of genetic and environmental factors. As in any disease, probably environments, bacteria, viruses, or toxin, or exposure to pollens, or to eventually toxic agents might affect what is called genetic susceptibility, mainly differences that all of us have in terms of genetic code that might impact on our interplay with the environment, and the combination of these two eventually lead to a specific disease. So in the two talks given by Dr. Wen Zhang and his group, and by Dr. Claudia Minici from my group, actually by Dr. Veronica Battani from my group. In the next slides, I provided you just the title of these two interesting talks that will probably move the field forward in the next year, trying to understand the genetic differences between patients with IgG4 disease in China and in a subgroup of European patients that may probably affect the ultimate clinical variability of the disease. How this genetic basis might impact the response to available drug in the future is still a matter of research, and will be a matter of research in the future. So to make the long story short, in the next slides, I summarize basically what we learned from this first day. Basically, that a better understanding of the epidemiology and the genetic basis of IgG4 will help us explaining why patients are so different among them in terms of clinical manifestation and response to therapies, and again, foster personalized therapeutic approaches.
So lots of work to be done in all of these areas, lots of very compelling questions for investigators from all over the world to collaborate on. Arezou Khosrowshahi, who is an associate professor at Emory, then spoke about, is there a time to stop immunosuppression? And here is a picture of Arezou on the right with our colleague from Japan, a nephrologist, Dr. Takako Saiki. So Arezou gave a very thoughtful talk. She pointed out that steroids are the cornerstone of therapy for inducing remission, really across the world, and most patients respond very swiftly to glucocorticoids. But maintenance therapy, sometimes with steroids, sometimes with other immunosuppressive medications, including mycophenolate mofetil, methotrexate, azathioprine, and leflunomide. All of these are used. Not a lot of great evidence for their efficacy, but they're all used all over the world. And then biologic therapies as well, in addition to those that are being tested in clinical trials. So the question of whether immunosuppressive medications can be stopped in IgG4-related disease involves an assessment, a balancing by the clinician and the patient with shared decision-making. There is a risk of continued immunosuppression. None of these drugs is candy. On the other hand, if we stop therapy, there is a risk of a disease flare or recurrence and damage, further damage to organs. So this is the balance that we confront. Our Chinese colleagues, led by Professor Wen Zhang at the Peking Union Medical College Hospital in Beijing, and Dr. Yunmyun Fei presented data that Arizu discussed, and Dr. Peng as well was involved in this study performed in China, which Dr. Khosrowshahi referred to in her talk. I credit the Chinese with a very clever title of their trial. It was called WINS, IgG4-related disease, with WIN standing for withdraw immunosuppressants and steroids in stable IgG4-related disease. It was the first randomized trial investigating the withdrawal of treatment for patients whose disease was felt to be in remission. It was an investigator-initiated trial. It lasted 18 months. And 146 patients were randomized. So it was actually slightly bigger than the Mitigate trial. Patients ranged in age from 18 to 75. They all had to meet the ACR-EULAR classification criteria. In order to be enrolled, they had to have disease that was felt to be clinically quiescent for at least 1 year. So in remission for 1 year on treatment. They had to have an IgG4-related disease responder index of either 0 or 1. So essentially in remission. They had to be on a maintenance dose of steroids less than or equal to 7.5 milligrams a day, and another of the immunosuppressive medications that I mentioned. The doses of those medications had to be stable, and these were the doses that were permitted. So it was a very carefully done trial, and I can't tell you how much admiration I have for Wen Zhang and her group for doing this trial. It was really quite an achievement. So then they randomized patients to either withdraw both the steroids and the immunosuppressive medications, or to remain on the immunosuppressive medications alone, or to remain on both steroids and immunosuppressive agents. And this is what we call a survival analysis. It's a maintenance in disease remission curve, or stated another way, freedom from disease flare in the 3 groups. The patients who withdrew both steroids and immunosuppressive medications, you can see every little downtick in this curve represents another disease flare in that patient population. So the patients who were withdrawn from both steroids and immunosuppressive medications fared considerably worse than those who remained on some treatment. With regard to the other two treatment groups, at the end of 18 months, they finished at exactly the same point, with 87% of the patients being in remission, whether they remained on both steroids and the immunosuppressive medication, or just on the immunosuppressive medication. So with regard to the conclusion, the maintenance of immunosuppressants with or without low-dose steroids is superior to withdrawing both steroids and immunosuppressives in preventing disease relapse. So leaving patients on therapy, not surprisingly perhaps, but very important to demonstrate, is more effective at keeping them in remission than is withdrawing it. But one of the most important lessons of this trial comes from the comparison of the two groups, one of which maintained immunosuppressants only and the other which remained on immunosuppressants and steroids. The findings in this trial, which showed equivalent results in those two arms, indicate that glucocorticoids can be stopped if the patient and the clinician feel that is in the patient's best interest. Patients can be maintained just on immunosuppressives and maintain remission to a similar likelihood. Emanuel, we'll turn now back to another highlight, that focusing on the gastroenterology aspects of the disease.
Right. In the last day of the meeting, actually, we discussed about four, I would say, debated and controversial topics in IgG4 related disease. With our increasing knowledge of the disease, with the increasing experience of many of us in the field in the last 20 years, we realize, or we are little by little realizing, that IgG4-RD, as most of immune-mediated disorders, is probably a spectrum or a continuum of immune manifestations that might complicate on the long run our overall approach to patients, and in particular our consideration for the prognosis. And these aspects require to be kept into consideration when starting our journey with the patient with IgG4 related disease. For what regards so these four debated topics were basically gastroenterological debated manifestations, the idea that IgG4 might also appear as a secondary form of immune disease in addition to a pre-existing autoimmune condition, IgG4-RD as a novel form of vasculitis, and also the approach and how we can disentangle inflammatory versus fibrotic manifestations of the disease. So these were the four debated topics that we discussed on the last day of the meeting. For what concerned the gastroenterology session, we focused in particular on two, I would say, chimeras, two entities that we still do not know how to appropriately consider. One is hepatic involvement of IgG4 inflammation, and the second is gastroenterological, or I would say bowel involvement of IgG4 inflammation. It's not uncommon, in fact, to receive consultation of patients with biopsies in their liver or in their gut, in particular in the large intestine, showing an IgG4 positive infiltrate. And the tendency is to consider everything that is infiltrated by IgG4 positive lymphocytes as an IgG4 related disease. But we know very well that IgG4-RD has a complexity around it that goes beyond the simple identification of IgG4 in the tissue. So next slides, we basically came to the conclusion that both the terms of IgG4 related hepatitis and inflammatory bowel disease basically are probably currently to be considered as a known reaction to some kind of stimuli, and so they probably do not reconcile with the classic spectrum of IgG4 related disease, requiring further research and further studies to be clearly deciphered. And in the next session, I think, John, we discussed about fibrosis versus active IgG4 related disease, and I know you're very fond of this topic, so I leave the mic to you.
Yes, thank you. This is really one of the most exciting presentations of the meeting, I believe. We are challenged to image IgG4 related disease. In particular, we're challenged to image the retroperitoneal fibrosis aspects. And this very exciting research from Germany, I think, points to a new way to do this, which I feel sure is going to be a source of important additional research and hopefully advances that move to the clinic over time. So Dr. Andreas Rahming from Erlangen in Germany presented this, and I'll present only a slide or two. Very often patients with IgG4 related disease undergo a PET scan, a combination of a CT scan and a PET study, which stands for positron emission tomography. The usual imaging agent used in a PET scan, at least for clinical purposes, almost all over the world, is called FDG, fluorodeoxyglucose. The point of Dr. Ramming's talk was that another imaging agent called fibroblast activating protein, this imaging agent targets fibroblast activating protein, may be a more sensitive indicator for fibrosis in this disease. So the essence of the study is really shown in this image. He and his colleagues looked at patients who had proliferative, so typically multi-organ disease, and patients who had fibrotic, more likely to be confined, for example, to the retroperitoneum. And what they found with regard to the retroperitoneal involvement, which is always hard to image, it's always hard to know whether the disease is active or not on the basis of our current imaging studies, was that using FOPI, fibroblast activating protein, they can target and image that, and they can visualize disease in the retroperitoneum. So if one thinks about the potential uses of this, there are potential applications in diagnosis. There are also potential applications with regard to when to retreat patients. We don't know very often when patients with retroperitoneal fibrosis are active again and when they need to be retreated. So this, I think, is a very exciting avenue of investigation that we will be hearing more about. Emanuel, there were some more evolving concepts of IgG4-related disease that you wanted to discuss.
Right. Simply two slides to mention very provocative talks given by Dr. Nicolas Schleinitz from Marseille and by James Stone, which is not your relative, but a relative of yours, but for sure a friend of yours working at MGH, about IgG4-related disease as a novel form of vasculitis. So Dr. Schleinitz's talk was, again, as I said, very provocative because he made us think about the possibility of IgG4-related disease complicating a pre-existing autoimmune disorder. This feature of the disease is not so frequent, but as I was saying earlier on, our 20-year history of patients coded and registered in our registries, in our cohorts, everywhere in the world, are starting pointing out some forms of poly autoimmunity, probably again driven by some genetic background that basically at the end of the day might come up with having IgG4-related disease together with rheumatoid arthritis or IgG4-related disease complicating a pre-existing sarcoidosis or vasculitis. Actually, in this provocative talk, Dr. Schleintz received a lot of criticism by the scientific community, but we all agreed about the fact that we probably as clinicians do not have to think about IgG4 as a closed box, but be open to the possibility that other immune manifestations might occur and be ready to correctly interpret them and to correctly approach them from a therapeutic standpoint. The second talk, provocative talk that was given by Dr. James Stone was about IgG4 as a new form of vasculitis. And the community was much more in agreement with this perspective, with this view of IgG4 potentially involving not only large vessel vasculitis. As we know from the literature, there are involvements of the large arteries such as the aorta and its branches, both in the thorax and in the abdomen. Well, Dr. Jim Stone, he's a pathologist, a very well-known pathologist, not only in the MGH, but also worldwide, basically accompanied us in a journey on histopathological pictures, fascinating pictures showing how Prototypical histological features of IgG4 in the large vessels might also be observed in vessels of lower size, such as those involving those, I would say, nourishing the kidney or the lungs or the skin, making IgG4 as a novel form of vasculitis of the medium and of the small vessels. So again, we need to keep our eyes open to potential new form of IgG4-RD manifestations.
I agree. That was a really compelling talk, and I fully expect that in the next iteration of what are called the Chapel Hill nomenclature criteria for vasculitis, IgG4-related disease will be included as one of the vasculitic diseases, or vasculitides, as we call them. I think Jim made a very compelling case that IgG4-related disease is what we call a variable vessel vasculitis, and that it can involve large, medium, and small vessels. So that's a very important new way of thinking about the disease, yet it is still a very distinctive disease, quite different from the other vasculitides.
Right, and this is basically what we summarized up from this third day of the meeting, underscoring the importance of a long-term follow-up of our patient, and in particular of experts in the disease who might appreciate slightly different features of the disease that might differentiate our patients from what is commonly said in the literature.
Okay, we're going to move on to the last couple of presentations. There was so much discussed at the meeting, so much interesting data. We couldn't possibly summarize all of it, what was talked about over the course of 3 days, but I wanted to call your attention to this very interesting study about the kidney disease from a group of nephrologists in Japan, led by Ichiro Mizushima. Kanazawa in Western Japan has always been one of the leading centers in Japan for the study of IgG4-related disease. Here is Kanazawa Castle and the cherry blossoms, which must be very pretty right now, and there is Kanazawa Hospital. So Dr. Mishuzima and colleagues raised the point that persistent renal insufficiency or slow kidney function can occur in IgG4-related disease despite good treatment. Even if we get patients into remission, sometimes the kidneys continue to have slow function, often because of damage. This is an image showing active IgG4-related kidney disease. These are the two kidneys here, pointed out by these white arrows. It's a CT scan, a cross-sectional image through the patient's abdomen. And all of the white areas here are normal kidney. These hypodense, as the radiologists call them, areas are the areas of inflammation within the kidney. After treatment with steroids, you can see that the right kidney has recovered radiologically. There's no doubt been some subtle or not so subtle damage to the kidney, but radiologically, it looks pretty normal. In contrast, this kidney on the left, and this is the patient's left kidney, maybe because of the more extensive disease at the time therapy was begun, has become more atrophied. The cortex of the kidney, the outer rim, is very, very thin, and that speaks to damage. Compare it to this kidney here and this renal cortex here, which is much thicker. So this kidney has not fared as well, despite the fact that the patient was in a steroid-induced remission at the time this follow-up image was taken. And Ichiro and colleagues indicated also that the long-term prognosis of kidney function in IgG4-related disease is unclear. Most of the individual organ system manifestations in this disease require careful further study. So these were the data that Ichiro and his colleagues shown. The key statistically significant findings are shown in red here. And these were the factors that influenced the risk of persistent renal insufficiency or slow kidney function following treatment. So a low or an elevated serum creatinine or low kidney function at baseline was an important predictor of future kidney dysfunction. The presence of hypertension was also a factor that predicted worse kidney function in the future. So control of blood pressure is very important in IgG4-related disease patients with kidney disease. And then the presence of fibrosis. A lot of fibrosis or a lot of scarring was associated with worse prognosis over time. And this really underscores the point all of these findings underscore the point that earlier diagnosis is really the key to ensuring a better prognosis for patients. And this is really one of our challenges now as for IgG forward and ER Reconet as well to get to the diagnosis earlier. So the conclusions from this study were that the best kidney function within the first 3 months of initial treatment really is the best indicator of how well the kidneys are going to do over time. The patient's baseline kidney function at the time treatment starts may not be the best predictor, and that is good because there is very often improvement with treatment. So the hopeful message from the study is that significant renal recovery can happen after the start of treatment, even if the kidney function is quite impaired at diagnosis. But the earlier we get to the diagnosis and start treatment, the better for patients' kidneys long term. And I wanted to close with this final study that was presented by Guy Katz. Here is Guy. He is a rheumatologist at MGH, and he described work that's been going on at our center investigating the complement system in IgG4-related disease. And let me emphasize that the word is complement with 2 E's and not an I. If I were complimenting Emanuel on his very nice tie, I would use this word, but with the I. But in measuring complement with 2 E's in IgG4-related disease, we measure 2 different things. We measure C3 and C4, the third and fourth component of complement as indicators of disease activity. And I think there's going to be a lot more research in this area. I won't belabor the complement system, which is very complicated. It's every medical student's nightmare to have to memorize these pathways, but it is emerging that these complement pathways are probably very important in IgG4-related disease and may affect treatment options in the future. Complement has, it's become clear recently, very recently, that it is involved in many diseases that rheumatologists and other immunologists think about a lot. But who would have imagined that complement is important in macular degeneration, a disease of the eye that, as far as we knew, had nothing to do with inflammation. Complement seems to be an important mediator of at least some types of macular degeneration. And complement has turned out to be a target for new therapies in autoimmune disease, including ANCA-associated vasculitis, which we've discussed in different contexts. So Guy very elegantly presented 3 controversies and I think resolved them quite well. One controversy is that the statement that the finding of hypocomplementemia or low complement in the blood means that the kidneys are involved. This has been a common belief now for 2 decades in IgG4-related disease, and Guy very effectively debunked that concept. In studies from patients from the MGH, he and our research coordinators and colleagues have demonstrated that low complement levels occur in patients with and without IgG4-related kidney disease, leading to the conclusion that low complement levels in the blood which occur in 40 or so % of patients, are probably more associated with the overall extent of the disease than by specific renal involvement or other kinds of specific organ involvement. The second controversy is that IgG4, which is so prevalent in the blood of patients with IgG4-related disease, is actually responsible for the activation of complement, leading to the participation of complement in the inflammatory cascade. Guy showed that this is likely also not true. There are a number of different kinds of IgG. There are 4 subclasses, as many of you know by now: IgG1, 2, 3, and 4. IgG4 is normally the least abundant of the IgG subclasses. And it turns out that the studies in this series of investigations really implicate IgG1 as being the molecule that is probably most important in leading to complement activation in IgG4-related disease. So that is an interesting turn of events in our thinking. And there will be some additional investigations of this concept coming up. And the final point that Guy made was to debunk another controversy, and that is the complement is, if it is activated, it is likely participating in inflammation, but hypocomplementemia as measured by C3 and C4 may not be found. And we need more sophisticated ways of looking at complement activation in the blood, and looking at complement activation products, or CAPs, are going to be one way that we do this moving forward. So with that, we could have gone on for a couple of more hours, but for me, it has been a continuation of the joy of those 3 days in Milan, being with our colleagues, again, Emanuel, for the first time in person in 7 years. And I want to thank you again, not only for joining us today in the middle of your clinic, but also for the wonderful job that you did as hosting us in Milan.
Thank you, John. It was a great pleasure.
Here is the picture that we will all treasure of the signature of the attendees. And I want to thank all of you for joining this fireside chat. We look forward to seeing you next month when Catherine Provencher and I will be back to answer your questions. We have lots of questions that we were not able to get to this session. We will try to tackle all of them at the next one. Please feel free to give us your feedback. There will be a survey for you to take right after signing off. Please do give us good feedback and constructive critiques, and have a wonderful weekend.